All right, let's dive in. Today, we're basically becoming medical detectives. We've got a really interesting clinical puzzle on our hands, a set of clues, a list of suspects, and a trail of evidence hidden deep inside the nervous system. Our case file, it's called Spastic Paraparesis.
So, picture this. A patient walks in and they've got this very specific cluster of problems. Their legs are getting stiffer and weaker over time, and their reflexes are, well, they're way too jumpy. Now, these aren't just random symptoms. They are all connected. So the question is, what's the link? That's the mystery we're going to unravel together.
And that link is a syndrome called spastic paraparesis. Now, here's the key thing. This isn't a disease itself. It's more like the description of the crime scene. It tells us what happened. There's damage to the upper motor neurons, those big nerve pathways running from the brain down the spinal cord, but it doesn't tell us who or what did it. And that right there is where our real investigation kicks off.
Okay, so like any good detective, the very first thing we have to do is examine the evidence at the scene. What are those telltale signs that absolutely confirm we are dealing with a case of spastic paraparesis?
The evidence is pretty clear-cut when you know what to look for. You've got this clasp knife spasticity, where a leg resists you moving it and then just suddenly gives way. You'll find those exaggerated reflexes and sometimes clonus. That's a series of rapid, involuntary muscle jerks. And of course, the classic Babinski sign, where the big toe shoots up when you stroke the bottom of the foot. All of these signs point their fingers in one direction. There's a problem with the upper motor neurons. Case closed on that front.
But knowing the patient has spastic paraparesis, that's really just the beginning. Think of it this way. We know how the crime was committed, but we have no idea who the culprit is. This is a symptom with dozens of possible causes, and our job is to go on a hunt for the clues that will unmask the real villain.
To solve this, we can't just guess. We need a methodical plan, a roadmap. So here's what we're going to do. First, we'll check for cerebellar signs to see if the brain's coordination center is in on it. Then, we'll look at the peripheral nerves, the ones in the hands and feet. And finally, we'll carefully assess for any sensory changes. Each step is going to help us cross suspects off our list.
Okay, first stop on our investigation, the cerebellum. Now, if the patient also has issues with balance, or their speech is slurred, or they have shaky movements, that is a huge clue. It tells us the brain's coordination center is involved, and that immediately shrinks our suspect pool down to just a few key players.
And just like that, with cerebellar signs on the table, our investigation zeroes in on two very different conditions. In one corner, we have multiple sclerosis, an autoimmune disease, and in the other, we have Friedreich's ataxia, a hereditary disorder. At first glance, they can look pretty similar, but trust me, they leave behind very different fingerprints.
So how in the world do we tell them apart? We look for the patterns. MS, being an autoimmune attack, often shows up with asymmetrical symptoms, affecting one side of the body more than the other. Friedreich's ataxia, on the other hand, is genetic, so it tends to be more symmetrical and leaves behind these very specific calling cards, like super high arched feet.
Of course, every detective needs definitive proof, right? That's smoking gun. For MS, an MRI that shows those classic demyelinating plaques, basically spots where the nerve's protective coating is damaged, that's our proof. For Friedreich's ataxia, it's a straightforward genetic test. We also look for known associates. MS often hangs out with vision problems like optic neuritis, while Friedreich's ataxia is commonly linked to a heart condition called hypertrophic cardiomyopathy, or HOCM.
All right, let's hit rewind for a second. What if our patient has no cerebellar signs at all? Well, our investigation doesn't stop, it just takes a different turn. Now we shift our focus to sensation. Can the patient feel a pinprick? Can they tell if you're moving their toe up or down? The answers here are absolutely critical clues.
One of the most specific and frankly coolest clues we can find is something called dissociated sensory loss. Get this, it's where a patient can't feel pain or temperature, but their sense of vibration and where their joints are in space are perfectly fine. Why? Because those signals travel up different tracks in the spinal cord. This tells us almost exactly where the damage is.
This one unique pattern points us to a really short list of suspects. It could be syringomyelia, which is a fluid-filled cavity in the cord. Or maybe an anterior spinal artery occlusion, a blockage of blood flow. Or it could be transverse myelitis, which is an inflammatory attack. See how that one clue narrowed things down?
So what happens if we investigate and sensation is totally intact? No loss of pain, no loss of vibration, nothing. Does that mean we've hit a dead end?
Absolutely not. In diagnostics, sometimes the absence of a clue is the most powerful clue you can get. If sensation is normal, it tells us the problem is pretty much confined to the motor system. And that leads us to a whole different list of suspects, like motor neuron disease, where we'd also be on the lookout for muscle twitches. Or it could be hereditary spastic paraplegia, or even a specific type of brain tumor called a parasagittal meningioma. Let's bring in one more crucial piece of evidence. Is there any peripheral neuropathy, meaning is there damage to the nerves in the hands and feet? If the answer is yes, our top suspects suddenly become Friedreich's ataxia again, or a condition called subacute combined degeneration, which is caused by a B12 deficiency. If it's absent, we're back to thinking about things like MS or some other localized problem in the spinal cord.
So you can see how we crack the case right. It's not about one single dramatic clue. It's about systematically combining all of our findings, the cerebellar signs, the sensory changes, the peripheral neuropathy, and using them to cross-reference the evidence, eliminate suspects, and finally land on the correct diagnosis.
And once the diagnosis is made, the focus shifts to management. We treat the underlying cause if we can, but a huge part of the job is just managing the symptoms directly to improve the patient's quality of life. This means using meds like baclofen for the spasticity, amantadine for the fatigue you often see in MS, and other treatments for things like pain and bladder issues.
Ultimately, what this whole investigation really teaches us is that in neurology, the pattern is everything. It's not about one single sign. It's about how all the pieces of the puzzle, the motor, the sensory, the cerebella, all fit together. Once you see that full pattern, the diagnosis pretty much reveals itself. Before we close the case file, I'm going to leave you with one final classic puzzle. What in the world does it mean if a patient has an absent ankle reflex, which points to a lower motor neuron or a peripheral nerve problem, but at the same time they have an extensor plantar reflex, that Babinski sign, which is a classic upper motor neuron sign? How can both possibly be true at the same time?
This seemingly impossible picture is actually a master clue. It points to conditions that affect both the central and the peripheral nervous systems at the same time. The culprits could be subacute combined degeneration, or Friedreich's ataxia, or even two completely separate things coexisting, like diabetes causing the neuropathy and MS causing the upper motor neuron signs. It's just a perfect example of the complexity and the pure elegance of clinical neurology. Thanks for joining the investigation.